Hello and welcome to this webinar, this special webinar, Closing the Gap, launching an independent review on health inequalities in Scotland. My name is Penny Taylor. I'm a journalist and a health and care specialist, and it's my great privilege to be chairing this important discussion. We're joined by members of the review. We'll hear from David Finch, Assistant Director at the Healthy Lives Directorate with the Health Foundation, Chris Cregan, the Expert Advisory Group Chair, Sir Michael Marmot, Professor of Epidemiology at University College London, and of course author of the groundbreaking 2010 Marmot Report and the 2020 Health Foundation follow-up. We're also joined by Carol Tannehill, former Scottish Government Chief Social Policy Advisor and former Director of the Glasgow Centre for Population Health. And last but by no means least, Katie Kelly, Deputy Chief Executive at East Ayrshire Council. Welcome to you. They'll be setting out the work that the review group is undertaking and responding to our questions. Now, some questions were submitted in advance, but we also want to hear from people that are joining this webinar. And just to let you know, there are more than 650 registered, so there could be a lot of questions. If you want to do that, please use the Q&A function that you find at the bottom of your screen. If somebody has already asked a question that you very much want to know the answer to, please upvote it. There's a thumbs up symbol I think you can use that indicates strong support for that, and that will allow us to filter the most important questions for you. And please share what you're hearing online using the hashtag HISReview22. So just to remind you that this seminar is being recorded, and in fact, it's going to be available on the Health Foundation website within 24 hours, which is quick work. And there'll be a subtitled version to follow. So let's just take it away. And to kick us off, please welcome David Finch of the Health Foundation, who's going to set the scene for the review.
Thank you, Penny. I was just making sure my slides are up, and hopefully people can see those. Just wanted to start off by saying thank you to everyone for joining the call today. It's great to have you here and to find out more about the review. For those of you that aren't aware, the Health Foundation is an independent charity whose one of our core aims is to improve health and to help reduce health inequalities. And we do that through a number of different types of activity, from funding longer-term research and also supporting frontline activity. With our knowing that the life expectancy at birth in Scotland is one of the lowest, or is the lowest of countries within the UK, and also the wide health inequalities that exist in Scotland. We've been very keen to understand more about what's driving the health of the population and those inequalities, and also specifically the factors that are influencing people's health in Scotland, which is why we've put together and are running this review of health inequalities in Scotland. I'm going to give you an overview of the review and some of the core components of it, and I will be quick so that we can get on to what I think you'll probably find is the more interesting part of this, which is the discussion with some of our panel members. The really aim of this is to produce a very high quality review of health and health inequalities in Scotland, and we really want that to have a lasting impact and legacy. And we think one of the important ways of doing that is making sure that we're providing a really robust evidence base for future policy development, and also delivery of policy, and with that focus on improving people's long-term health and reducing health inequalities. I think as with two kind of things that we do come to this review with are first off a focus on the importance of the conditions and day-to-day experiences that people have in shaping people's health. I think that's a very important of the sort of key drivers of people's health, and something we want the review to be focused on bringing out as we go through it. But then also that we're very keen for the work to be rooted within Scotland, and that's why we're funding different strands of research, and also the advisory group we've put together, very much rooted in Scotland, and can help to bring that perspective to the work. That's something important for the research side, and also engagement that we do hope that people on this webinar today who are interested or do please engage with us, have questions or have further interest in this. That's something we're very keen to happen, and make sure that the work is very much rooted within Scotland. That said, although we covered those two priors, we're also coming to a very open mind as to what the review will conclude and where we get to with this. We're very much wanting that to be led by the research and the advisory group we put together. The review itself we're planning for it to run until the end of the year with the Health Foundation overarching report finishing off, but also reports from the different strands of research published through the autumn. I will just move on to those specific strands of research next. So there were 4 key strands of research that we're funding for the review. First is focused on public health trends and health trends over the last 2 decades. That's been led by Anna Pearce at the Social and Public Health Sciences Unit at Glasgow University. The second is a study of trends in the social and economic drivers of health. So they're led by David Idle at the Fraser Vallender Institute. And so between those two, it's really examining the trends and those factors trends in health and the factors that drive health, and trying to understand how and why those have changed over the past 2 decades. And then also supported with 2 more strands of work where there's public engagement strand being led by the Diffin Partnership, and a stakeholder engagement process of stakeholder engagement led by Adam Lang at Nestor in Scotland. And really the intention here is to make sure that all 4 of those research packages are working closely together and speaking and informing each other, so that we can build a really strong picture of not only what's happening in the data, but also what's happening in people's experiences and the experiences of people involved in the delivery of all the different things that support good health in Scotland. The final slide is just to talk about the expert advisory group. There's a lot of names here, a lot of text. I'm not planning to go through all of these names in detail. They're on our website if people are interested in looking there. It was really just to flag that we have put together a really great group of experts from across a range of different perspectives, because of that acknowledgement we have of the kind of importance of this wider range of factors that influence health, and they're really here to help steer us in understanding and interpreting research as that develops, and forming our narrative on for our final report as well. And I would just finish on by saying that we're lucky enough to have some of the members of that panel here today to help inform our discussion. And the panel, our advisory group is being led by chaired by Chris Freeman. So I will leave it there, other than just to say thank you very much for your time today, everybody, and do please engage through, I think there will be links in the chat and things. Do please either engage directly with us or sign up for more information about the review. Thank you.
Thank you very much. Thank you very much, David. Before we go to the members of the expert advisory group, just like to remind you that if you're joining this webinar remotely, please, if you've got any questions, put them in Q&A. I see there's one there. They'll either be answered live or we'll put them to the panel for you. And also that biographies of our panel members are available online on the Health Foundation website. And I think we'll be putting a link into the chat box for that. So to take this discussion on, I'd like to turn first, please, to Chris Cregan. Yeah, as chair of the expert advisory group, Chris, I've been covering this field for decades in Scotland. We've been talking about this for such a long time. What's going to be different about the work of this review, on top of what we already know?
Thanks, Penny. It's great to be here and good to see you. Four things I want to mention. The independence of the review, its timeliness, the very comprehensive coverage of it, and its deliberative focus. I think are key things about what attracted me to be involved in this review as what's rather grandly titled a strategic advisor, but really helping the Health Foundation navigate the Scottish policy landscape. So it is an independent review. It's been commissioned by an independent charitable organisation whose expertise and focus in the field of health and health policy is renowned, and it will build on recent work commissioned by the Health Foundation to review health equity in England by Professor Michael Marmot, who is fantastic. We have involved in the group and who's here today. And that independence will be reinforced, I think, by input from the advisory group, drawing on a really wide range of knowledge, expertise, advocacy across sectors and policy areas, social, economic, clinical. So it's enormously timely. It's happening at a really critical moment for policy reflection on health inequalities, and indeed inequalities more broadly in the wake of the COVID-19 pandemic, something that the Foundation's also conducted its own inquiry into. And timely as well, because there's a lot of concern in Scotland at the moment about, and focus on, about the problem of what we call the implementation gap. Why do we have a situation where we have arguably good policy, great policy, but weak implementation, poor outcomes, and in this case, widening inequalities as a consequence of that? It's going to be really comprehensive. It's rapid, but comprehensive, both in terms of the depth and breadth of its retrospective lens on evidence, on data and trends. We're going all the way back to 2000, to the creation of the Scottish Parliament, and in its current lens on stakeholder and public perspectives. And finally, it will go further than an analysis through its deliberative focus, albeit, as I say, within a relatively rapid timescale, so that these strands that Dave has talked about are connected to one another, and ultimately ensuring that the conclusions that I hope that we reach about future policy direction are informed by and co-designed with a really wide range of experts and stakeholders and citizens.
Okay, thank you. We've had a couple of comments in. One question from David Welsh, basically saying, what will it tell us that we don't already know? Is that an objective of the review? Are you looking for, the magic ingredient, the silver bullet, Chris?
I think one of the silver bullets we're looking for, Penny, is to understand, as I said, why we have a situation where we've had laser focus on health inequalities, good policy, but why hasn't change happened? And that's not just a problem that applies to health inequalities. I hope we can shed light on the wider issue. I think that will be a really key nugget, I think, for us to get to grips with.
And then let me pick up another comment that's come through. Alan Eagleson from THT Scotland saying, great to see SCVO on the advisory board. However, will any of the Scottish health-based membership organisations for the voluntary sector be involved? Endorsed by Lizzie Edwards, who's got some suggestions for how to engage there. So it's great that so many people want to be part of this work. How can they play in, Chris?
So I think the work that is being led by Adam Lang and his team at Nesta is critical. They're engaged in a series of roundtables at the moment, the first of a series of roundtables. David Finch and I, to the question from the colleague at THT, David Finch and I just met the other day actually with colleagues from Voluntary Health Scotland, to talk about ways in which we can connect with them and their membership through the life of the inquiry. So it's very much something that's uppermost in our minds, Penny.
And evolving, it sounds. So thank you very much for that. Can I move, please, now to Professor Sir Michael Marmot? Your 2010 report was really groundbreaking in terms of addressing what was opening up as the inequality gap at that point. And it's been refreshed with a 2020 report from the Health Foundation, which obviously predates COVID. So, Michael, what has happened as a result of the work that you've done to date before this review? You're on mute, sir.
Sorry.
Thank you.
You'd think after 2.25 years I would have learned. Let me talk about England, and then the question is how it applies to Scotland. In the 2020 10 Years On review that we published just before the pandemic crashed upon us, we documented the fact that life expectancy had more or less stopped improving. And that was for England, but it's very similar for Scotland. Health inequalities were getting bigger, and life expectancy for the poorest people outside London was going down. That was pre-COVID. Then came COVID, and it exposed and amplified the underlying health inequalities. And in relation to David Walsh's question, I don't think we need a new program of research to understand this. A new program of research would be 5 or 10 years. It wouldn't be producing a review within a few months. What we need is action. And we need action within the context of Scotland, just as we need action within the context of England. When we look at the impact of COVID, as I said, it exposed and amplified the underlying inequalities, what I've described as the social gradient in mortality from all causes, looks very similar to the social gradient in mortality from COVID. One big surprise was the excess COVID mortality in different ethnic groups, Black Caribbean, Black African, Bangladeshi, Pakistani, and to a lesser extent, Indian. That was to some extent socioeconomic, but not completely. And that needs to be addressed. And figures that were published in the US on the 29th of April, so quite up to date, showed that of 19 rich countries, the US had the biggest decline in life expectancy in 2020, and Scotland had the second biggest. Yikes. Wasn't doing well pre-COVID, and it didn't really recover in 2021. The US continued to fall in 2021. Scotland didn't really recover. And Scotland, Northern Ireland, England and Wales, among the 19 countries were, and Germany didn't look good, were the ones, the US was worse. Scotland, Northern Ireland, England and Wales were among the worst. So we were doing pretty badly pre-COVID, and we did even worse during COVID. And we need to address that. And then comes the cost of living crisis. The figures for the poorest people, I've quoted the figures from the Resolution Foundation, taking a single parent with one child, earning a low to medium wage, working for 20 hours a week. This parent will be £584 a week worse off between 2021 and autumn 2022, £584 a week. And that's before the further rise in energy prices. Now, if you're middle income and you lose £584 a year, sorry, I beg your pardon, £584 a year, £11 a week. If you're middle income and you lose £11, you notice it. If you're at the margin and you lose £11 a week, this is ghastly. Forget new clothes for your children, forget eating, let alone heating. This is absolutely ghastly. And so just to round off where we got to, and I think they will apply to Scotland, we had 6 recommendations for England, and we've now added 2 more. The 6 were give every child the best start in life, education and lifelong learning, employment and working conditions, having enough money to live on, healthy and sustainable places and communities, and taking a social determinants approach to prevention. The 2 we've added are addressing structural racism, discrimination, and their consequences. And the 8th one is to put together the climate change agenda, the sustainability agenda dealing with the climate crisis, and the health equity agenda. So what I'm looking for in this Scottish review is to take these insights and say, how can we get action within the Scottish context?
Yeah. As your work resulted in action in the English context, I suppose I'm thinking of levelling up.
If somewhere between disappointment and blankness went over my face when you asked that question, the Levelling Up white paper had a brilliant analysis, 4 objectives, 12 missions of what was wrong. There was one small problem, not putting any money into it. Not putting any money into it, peanuts. And we've been working, because of the lack of action at the national level in England, we've been working with regions, Greater Manchester, Cheshire and Merseyside, Lancashire and Cumbria, north of Tyne, Luton, Waltham Forest, and now Gwent wants to be the first Marmot region in Wales. And one of the issues for the Scottish Review, what we've seen in the north of England and in Wales, is that the consequences for ill health of deprivation are larger in the north than they are in London and the southeast. And if that's true in Scotland as well, and I suspect it is, David Walsh's work in Glasgow shows that it is, then one's got to understand why is a given level of deprivation worse, particularly, and I suspect it's worse in Glasgow than it is in Edinburgh. Why is it worse in Scotland than in England? And why is it worse in Glasgow than in Edinburgh, a given level of deprivation? And I don't think we understand that very well, but that's a major issue, and a major issue for taking action.
Several people are making the comment as well that in Scotland, we've got the remote and rural versus the urban issues to consider. We'll come back and pick that up. But if I might mention as well, Michael Marbut, Tressa Burke from Glasgow Disability Alliance has made a comment and asking, you know, in terms of pockets of deep and deepened inequality, disabled people figure large. Are they going to play a part, and their experience going to play a part in this review, do you think?
What we've seen, we did a report, people with learning disability, but it's true for people with other kinds of disabilities. The social determinants of health apply to those people even more so.
Yeah.
So exclusion from society, whether it's jobs, housing, income, education, all of that applies even more so. And life expectancy as a consequence is shorter, health is worse. And a caring society will actually take the action that's needed to deal with everyone in society, including the most vulnerable.
Yeah. Thank you very much. Now, can I move on to Carol Tannehill, please? Carol, you've got, you know, a grasp on how the delivery or the development and delivery of social policy works in Scotland. We've heard many references to the implementation gap. Gordon McRae, for instance, in the Q&A, is saying, to what extent does the panel believe that the so-called implementation gap is down to a failure to deliver versus a political choice not to deliver reforms, and resources, as Michael Marmot has pointed out, to deliver? What's the block, Carol Tannehill, right at the top?
Well, thanks, Penny, and good afternoon, everyone. It's a real pleasure to be here today. I think this issue of the implementation gap, the question arises partly because Scotland has got such good analysis on health inequalities and has had a number of reviews with recommendations, and yet we continue to have some of the widest health inequalities in Europe. So that's the question. What's missing, and how can the change happen? And I think these are two slightly separate issues, the what and the how. If I take the what first, we know that action on health inequalities needs to happen across three different levels. So we need action on the fundamental socioeconomic circumstances, and we know there's been an increase in socioeconomic inequalities in Scotland over recent years. The second level is about wider environmental influences, things like housing quality, quality of neighbourhood, quality of work, etc. And the third is about individual experiences, so how people are treated, issues to do with communication, issues to do with stigma, issues to do with racism that Michael has mentioned, etc. Now, we need action across all three of these levels, but without action on the first, health inequalities won't be reduced. So there's something here about the what. Now, we do have a really good policy context in Scotland for a lot of this. The commitment in the Child Poverty Act is absolutely fundamental here, and is in law. And the recent Child Poverty Delivery Plan has got some really ambitious and important aspects to it. So we should, over coming years, see effective action on child poverty if that's implemented. We also have work towards a minimum income guarantee. That will be really significant if that's implemented. A lot of work on children and young people, good start in life, additional childcare, free nursery places, etc., etc. So I could go down a long list of policies, but what's missing, I think, is the overall framework, this sense of a concerted effort across all policy areas directed towards improving health in the poorest communities and addressing those socioeconomic determinants of ill health. And so the question is then, what is that framework? We have some opportunities coming up with the COVID recovery strategy, and that is going to try and pull together policy from across a range of areas in Scotland, and I think addressing health inequalities needs to be a really central part of what the COVID recovery strategy does. Scotland's also part of the Wellbeing Economies Alliance, and that aspiration to have an economy that's fair and inclusive, founded on community wealth building, that's green, also could be a sort of overarching framework that helps bring together all of these different policy initiatives, because we've got a lot of activity, but it's not necessarily all adding up to what we need. So I think that's the what, Penny. The question on the how is possibly trickier. How do the changes happen? And I think there's issues obviously about resourcing. We know that, we're entering another huge global economic downturn. We know that the fiscal settlement for Scotland is really tight. So there's going to be some very difficult decisions to be made about prioritisation and resource allocation. And that requires leadership that's absolutely committed to investing in prevention and investing in those communities where it's most needed.
And do we have that commitment?
Yes, I think we have, but I think it's always tested. There's always so many demands, aren't there, on decisions and so many priorities. But I certainly am a glass half full person on this. I do think we do have the commitment, but
politically
we can't. Yeah, politically, yeah. I really do think we do, but we can't pretend it's easy. And
well, here's a question from an anonymous attendee asking, how achievable are the potential proposals or recommendations that are going to come out of this review, how achievable are they in the current political landscape? I mean, I suppose that question is possibly referring to constitutional issues there. Sure. I mean, are we hamstrung in Scotland?
So, of course, there are some things that would make a real difference that are not at the moment devolved. You know, so we are doing a lot on social security, but there are some benefits that are reserved, etc. So, yes, of course, we are slightly hamstrung by that. I think the job, though, of this review is to make sure that the recommendations are implementable, to help show how they can be implemented, to draw on all the good practice that does exist, and really get underneath. You know, we need to present really good analysis, but we also need to show how the changes can happen and that they are achievable. And if we're making recommendations that can't be delivered, then that's not going to be useful, is it?
Okay, thank you very much. Now, Katie Kelly, you bring the local authority perspective on this. You know, we've heard a lot about involving people, and in fact, there's a really interesting comment come in. There's so many of them coming in. I'm scrolling through. Please try and keep your questions short because it takes a long time to read some of them. You know, about involving people, Katie Kelly, what's the role of the local authority in this agenda?
Thanks very much, Penny, and good afternoon, everyone. Really interesting question, and I think it takes me back to the local context and this focus on people, place and power. And I think they're going to have, you know, around a whole well-being economy that was mentioned there, Carol, so important. I think for me at the moment, public services, if I can even talk wider than just public local councils, but into police and fire and all of my colleagues in local public service, we are at a crossroads just now, and we've been on a historical journey. If you think, you know, Beveridge and the reports that were set up after the war, how we are shaped. I don't think, and I'm going to be quite radical, I know this has been taped and I'm voting myself out of a job, but actually public services is not, in the way it's set up just now, isn't as fit for purpose as it needs to be in the 21st century to reduce inequalities. You know, we talk about the implementation gap, and everyone's very, very well-meaning, but actually very much public service has been about delivery, and it has become over the years very much about dependency and creating dependencies and actually moving away and more centralised and moving away from the people that they serve. And actually what we found is that the closer you get to people that you serve, the more you can understand and hear their voice, and actually they should have power over their own lives. And we know that when people have self-determination and power, something changes around their health and well-being. So I suppose from my point of view, you've got 32 local authorities in Scotland, but also you've got Police Scotland and you've got Fire as well. And we work collectively. I think that shift away from being a service deliverer and a provider, creating dependency, even being a fixer, you know, so a lot of the policy comes down and some resource comes with it. And, you know, locally people try to fix, but actually the fix isn't going to work. It needs to be about us as an enabler, as an empowerer, and our job should be to work alongside the people we serve to help them to co-produce, be part of the solution to the problems that we're hearing about that are there.
Is it local enough at local authority level? I'm going to refer to a comment here, and this is the one I was trying to find earlier. Sarah Curtis saying, in a recent review responding to the government inquiry on health inequalities published by the RSE, one point raised was that it's essential there's a bottom-up approach as well as a top-down approach across government agencies. Local initiatives that will effectively address health inequality may vary across different communities. Attention needs to be paid to promoting the potential for local communities. You know, I've been doing some work with the Wellbeing Alliance, and it really, the importance of community. Sir Angus Dayton in the USA has talked about a democratic deficit perhaps playing into this agenda. Katie, can local authorities do more to devolve some of the powers that are held and to trust communities to come up with solutions?
Absolutely. And, you know, I think this is the key, is about community power and unlocking power in communities. People have become very disenfranchised, and, you know, and policy sometimes and structures have inequalities built in, not for any reason. And my experience has been where you work closely with communities without an agenda, not with saying, what do you think of this policy, but actually what matters to you, and then how might we work alongside you in partnership across sectors, not just public sector, the third sector, the community sector. I think we need to transcend sectors, be deep into place, understand the needs and wishes of people, and some of the health inequalities actually start to fall into place. Some of them come from loneliness and isolation, and yes, others are linked to money, and that brings in what Carol mentioned there, and I greatly believe in this, and I'm starting to see some brilliant results coming out around community wealth building, where wealth is very local, people have power over that, and actually the economy becomes much more linked to humanity, and much more linked to about how people can thrive. So yes, there is a different role for public service. I think we need some quite radical reform to help us to set up in a different way to respond and implement policy. And my final point, Penny, is really about resourcing. Everybody's talked about it. There's been millions of pounds thrown at health inequalities over the years, and I've been part of all of that over 30 years. But it's short-term, tends to be linked to spending reviews. This needs deep investment, and and also the money that goes needs to be very much focused on the things that matter to people, and not what the professionals think that the people need.
And evidenced, and we'll come back, I hope, to some of that. Now, yesterday we had local authority elections in Scotland. We're still hearing the results coming in. Did these issues, in your experience, Katie, in your patch, did health equalities feature in any of the discussion in the run-up, in your experience, to these local authority elections?
I think, you know, if you went into communities and talked about health inequalities, there's a bit of a turn-off for people. And actually, I've seen, you know, communities discovering the statistics that we have about them and being horror-struck about high levels of crime, low levels of educational attainment and health. But I think what has been important to communities, certainly in East Ayrshire, there's an appetite now with nearly 30 communities with their own action plan that's not ours, is they want more power to make decisions for themselves and to have a greater influence in the services. And I suppose to recognise that we are servants of theirs, that actually, so it is that bottom-up approach, it's flipping the dynamic.
Yeah, and East Ayrshire's doing amazing things in that regard. Is there a chance of rolling that out across Scotland? Because we hear so much all the time about postcode provision of good practice. Presumably this review is going to make recommendations that can be applied.
Yeah, and I think the way to roll it out isn't necessarily to write up a case study, it's actually to connect people horizontally. So the work in East Ayrshire, communities now are engaging with communities from East Ayrshire, engaging with communities in Perth and Kinross, in Renfrewshire and other places. Actually, rather than it being, you know, again, going from bottom up to some kind of, thing that's shared, actually it's better for people to share, because actually then we see a movement of change and that people realise that they can have that ambition. So sharing's important, rolling it up and scaling it up is important, but actually it should be done in a way that's horizontal. I don't think it should be done in a way, I've seen the best sharing and scaling up by people engaging with people, rather than actually having to be filtered through a professional lens.
Thank you so much. And thank you to everyone that's contributing to the Q&As. If we don't get round to your specific question, don't worry. I know that every effort will be made to address your questions. If not now, then bide your time. But we're going to open up now into take questions. We have some questions submitted in advance. And our first question, but I'm not sure if the person asking it is here, Kirit Mistry from South Asian Health Action. And Kirit, if you're here, you'll pop up on my screen imminently. If you're not, let me frame this question for you if I can. I'm going to boil it down from service-specific issues. Our focus is on the social determinants of health, so forgive me if I sub it too tightly. But I think I heard Michael Marmot say very much that you're going to look at race issues, for instance, disability issues. Co-production and co-design is something that's talked about a lot. Chris Cregan, what co-production and co-design, again, just to outline once more, how, because there's a lot of questions on that coming through in the Q&A, how can people engage with this review on that basis?
So I think, thanks, Penny. Thanks again. Yeah, I'm scrolling through those questions as well. A lot of people have been getting in touch with us and continue to get in touch with us. And obviously we're in the process of responding to all of that. And I'm talking to David about how we can respond to that through the work that Adam Lang and his team at Nesta are involved in, and in the way that we think about how further iterations of that work and the work of the review roll through the rest of the process. Co-design is part of the building co-design into this is very much at the heart of how we want to arrive at the overarching narrative, and it's built into the review process. I think it's also worth emphasizing, and you know, Katie's a real champion for this, co-production and the shift of power, which is fundamental to the efficacy of policy intervention, is a really key issue for Katie and other advisory group members and many of the stakeholders with whom we're engaging. So I think as we look to, and when we're thinking about the implementation gap, as we look to shape our overarching narrative in relation to future policy direction, we've got to think about how, what kind of action is required to shift persistent and widening health inequalities, and how co-production can be harnessed is something we're going to need to consider, as well as how we understand and involve the experiences and insights of those who live with health inequalities.
Yeah, and you've got, you know, the two strands of research that are around stakeholder engagement, stuff like that. What are you hoping that they're going to tell you? Are they exploring these issues in greater depth then?
Absolutely. So we have through the work that Adam and his team are leading at Nesta, reaching a very wide range of stakeholders, including those like Tressa and others who advocate on behalf of those with lived experience of health inequalities. And then the public engagement work that Mark Diffley and his team are leading to give us real insight. And as I said earlier, you know, importantly, both of those strands of work are deliberative, so they're iterative through the life of the review, so that we're constantly informing and building on the evidence and analysis.
Thank you. Now we have so many questions. I'm going to move us on. Myra Murray, are you out there? You've put a question up, and I wondered whether you would like to ask it in person. If you don't want to, that's absolutely fine. If you do, I'm sure you'll be brought up on the screen in a second. If Myra isn't there, are you there?
Yeah.
Are you there?
Yes.
Great. Can you ask your question? Will you make it as succinct as you can?
Yes, indeed. So I suppose I'm inquiring to note that there are lots of, you know, on the ground community organisations, services, both voluntary and funded ones, that are doing and have done really important and impactful work, but because of poor evaluation and perhaps lack of advocacy, some of these programs and projects have died off due to funding or other issues. And are you going to look at, I suppose, what has worked well in the past and perhaps is not currently happening? And equally, there are pockets of excellence in Scotland. And is that going to be a focus of your review?
Have you got a particular person you'd like to put that question to, or can I choose for you?
You can choose, Penny.
Okay, thank you. Carol Tannehill.
Thank you. Thanks, Myrid, and thanks, Penny. And Myrid, I think this is a really important issue, isn't it? So there's a number of aspects to your question. One is the paucity of good evaluation of small local initiatives. And this review isn't going to solve that. But I think it's something that, you know, collectively we all need to keep attending to, because there's no doubt there's a lot of really good work, but it's very hard to evidence the impact it has and to do that in a way that has traction. So that's an issue, I think, not for this review, but it's a really important issue to highlight. But the other aspects of your question is, you know, will this review engage with examples of good, effective practice in local communities, and also take account of the evidence that does exist about the features of community action that help address inequality and improve health in some of the poorest communities. And I'm just looking to Chris here, but yeah, I mean, I think absolutely yes, these are important aspects of what this review will do. So we'll have terrific epidemiological analysis, but we're absolutely wanting to bring alongside that a good understanding of the situation in Scotland in terms of practice. And I just make another point here. I mean, people ask quite a lot about international comparisons, and of course they're useful, but the solutions to addressing health inequalities in Scotland need to fit and take account of Scotland's own strengths and the particular challenges in Scotland. There's no point in us wishing we were like Finland. You know, we are Scotland and we've got great strengths in Scotland and lots of really good initiatives, and we need to build on those.
Thank you. Katie Kelly, it must make it quite difficult for local authorities to know that they're allocating funding resources effectively if we don't have the research.
Yeah, absolutely right. And this one really resonates for me. And, you know, I'll give you examples. So basically, something really good happens in a community, and it might be led by the third sector or the community sector, and it's using external funding to try something new. That external funding is usually temporary. It's come, you know, either nationally or locally through a grants programme. Even if the very best research shows it works well, the issue then is how we sustain it. And that's what's really frustrating for me. And actually this kind of flip-flopping of resources being invested and then reduced actually exacerbates inequalities. Yeah. And my premise then isn't really about whether we've got good research or good, it's about, are the systems set up to allow good practice to be mainstreamed and amplified? And currently the answer is no. If something good develops out with a system, it's a wee bit like the Bible. If you're in the vineyard and the grapes grow, everything's fine. You could grow really quickly, but in thin soil. But if you aren't part of a system, you can't continue that on unless it finds a way of just making its money and making a return. So I'm interested in terms of how we provide a fertile ground for good practice out with systems and across sectors. This is so important to thrive, and also to be honest to say that isn't actually working and we need to pull it away. So my biggest concern, what makes inequalities worse in this landscape, is the withdrawal of funding even when something's doing well. And so there is an expectation in councils to continue something that's doing well, and sometimes they would absolutely want to do that, but the resources that they're getting nationally are reducing as well. So there's a competing thing on resources. So the way it's resourced, but also the way that we set up systems to allow innovative good practice to grow and thrive, it should be part of the system of this. Is interesting. And
defining what well looks like. Yeah. David Finch, coming to you. The research that this review is undertaking, I've heard described as the evidential backbone of the review. Can you describe and you know, then I'd like to hear from Anna Pearce at the University of Glasgow and David Iser at the Fraser of Allender Institute. Is the research going to address this particular question? You know, how do you measure what's working and what doesn't, or what isn't?
So it's the research itself, it's not trying to, it won't be trying to fundamentally kind of very causally assess the impacts of specific policies. I mean, that would require quite probably more time for one thing than the review at the moment. But what we do want to understand is how, you know, what has happened to health trends over the last 2 decades, and also those factors that are influencing health, and map that across to you know, changes in policy over that time period as well, so we can start to get that understanding. But I would say as well, you know, I mean, it is so good to see the level of engagement we're getting through the webinar, and you know, where people do have these examples, if they can share them, that would be fantastic, so that we can kind of feed them in.
Wonderful. Let's hear a little bit more about that research. I wonder if we have Anna Pearce from the University of Glasgow here to describe the work you're doing on this review. If so, say yay. If you're not there, then perhaps we can go to David Eisner from the Fraser of Allender Institute.
Anna is here.
Anna, great. Welcome, Anna. I wonder if I could ask you, I'm sorry to do this to an academic researcher, but could you make it tight, your answer?
Oh, I'll try. So yeah, I guess just to start by saying we're really excited to be part of this work. So our main task at the University of Glasgow is to describe trends in health inequalities in Scotland and how they've changed over time. So this sort of epidemiological analysis, as it's been described. And looking to some of the questions in the chat, there's lots of really interesting points coming up. I guess a few things just to sort of reflect upon is we are going to be drawing upon work that's already done. There is a lot of great stuff out there. But in terms of the health outcomes we're looking at, we're trying to keep them Scottish relevant. We're keeping them relevant to different stages of the life course to make sure we've got good coverage there. So looking at early years and healthy aging. And then in terms of different socioeconomic groups or social inequalities, we'll be doing our best wherever we can to cover the different groups that have been mentioned in the chat. It might not always be in data over time. We might be doing sort of case studies and more in-depth sort of explorations of issues around ethnicity, people with disabilities, those experiencing multiple disadvantage, looking at rurality, that kind of thing.
Thank you so much. And David Eisner, I don't know if David's there to talk about the piece of work that the Fraser of Allender Institute is going to be doing.
I am here. Can you hear me?
Fabulous. Great. Once again, could you make it snappy?
Okay, yes. Good afternoon, everyone. So the work that the Fraser of Allender Institute will be doing as part of this is to be looking at how the key socioeconomic determinants of health have evolved in Scotland over the last 20 years or so. So what we mean when we're talking about the socioeconomic determinants of health, it's broadly those things that Michael Marmot mentioned earlier when he was talking about his 2010 report and the 10 years on work. So it's looking at socioeconomic determinants in terms of things like employment, the nature and quality of work, household financial security and living standards, housing quality, security, affordability, education, participation and attainment, neighbourhoods and community, both in terms of the sort of physical aspects of neighbourhoods, but also the community and social aspects of neighbourhoods as well, and access to and experiences of public services. Picking up on some of the points that have been mentioned already about funding of public services and so on. So it's a really broad look at the socioeconomic determinants of health, how those have evolved, not just for the population as a whole, but for different groups within the population, and how people's experiences of these things have evolved differently over time. And as far as possible, putting these trends in the context of the types of policies, the types of economic developments that have influenced those trends. So like Anna, we're really excited to be doing this work. I think, you know, somewhat surprisingly, I don't think there has been a really comprehensive analysis to date of how these socioeconomic inequalities in Scotland have evolved since devolution in 1999. Certainly no, really good attempt to link those to health outcomes and health inequalities. So we hope that this can really make the difference in terms of helping people see that bigger picture.
Excellent. Thank you so much. I wonder if I could go to Sir Michael Marmot now to respond to a question that's come in from Andrew Moran, which is, will the impact of businesses on the health improvement agenda be looked at? Do you think that would be of value? What can businesses in Scotland do to support this drive, as well as public services? Michael Marmot.
Yeah, we've just produced a report called The Business of Health Equity, the Marmot Review for Industry.
Wow.
And in public health, for good reasons, we've seen business as the enemy, for very good reasons. And I'm not dropping my skepticism that there are all sorts of ways that business can damage the public health, no question about it. but we're trying to help business get onto the good side. And we've said that there are three crucial areas. They're pretty obvious what they are. The first is employment. Do you pay a living wage? That's pretty basic. All businesses should pay a living wage. And as part of employment, security of employment, on-the-job training, promotion prospects, and the like. So, and there, it ought to be pretty easy because it's in the interest of business. It's a win-win. In the interest of business to treat their employees well. The old model of management that the beating won't stop till morale improves is an old model of management. A newer model.
And in practice in some places.
Well, there are a lot of people still wedded to old ways. We know that. Look at the Supreme Court in the United States at the moment, wedded to traditions from centuries ago.
Or P&O as a major employer and the way that they dealt with that.
So, absolutely. So that's absolutely wrong. And it's not in P&O's interest to treat employees.
Other brands are available, just to remind everybody. But
the second crucial area is goods and services. Tobacco, well, that's easy. Don't sell tobacco. But food, we all rely on food. We don't grow our own.
Absolutely.
More than half the global population that live in cities need the food industry. Is the food industry going to make us all fat with diabetes? Or is it going to make nutritious food available at an affordable price? And the third domain is the impact on the environment and the society. And what we've done now, and I'd like Scotland to perhaps join, what we've done is created a network funded by Legal & General in England with local government, the voluntary and community sector, the integrated care systems, and now, for the first time, business, where we want action at local level and mutual learning. So Coventry was the first Marmot city in England. The indicators coming out of Coventry, modest, but look like they moved in the right direction. And we want a monitoring framework. In our work with Greater Manchester, we proposed 24 beacon indicators to monitor what progress is being made, and industry should be part of that.
Thank you so much. Chris Cregan, you wanted to come in there. I saw you nodding as well, Katie Kelly, but I'm going to have to move us on after this.
Yeah, no, I mean, obviously detailed answer there from Michael Penny, but I guess I just wanted to make the wider point that, you know, we do not see this review as being about, you know, 191 recommendations for the Scottish government. This is about the wider determinants of health, and therefore what we're focused on is action across sectors,
right?
You know, across levels.
You've got somebody from an investment company on the review board, haven't you? So you know that's you know part of the process.
Absolutely, and I think we know. You know, I know from my experience, you know, working with you know people with learning disabilities, that it takes partnership and collaboration between employers, between the education sector, between third sector advocacy organisations, public services, and so on, to get people into employment.
And businesses haven't been forgotten, right? Absolutely. Katie, I just wanted to come to you briefly on this one because you were nodding your head so vigorously. At a local level, how important is it to think about that sector? And if you can make it brief.
Very brief. So just focus on the wellbeing economy. Some of the biggest investment into Scotland is through the growth deals, which are funded by Westminster and Holyrood, hundreds of millions of pounds in terms of regional growth deals. And these need to be inclusive and inclusive growth, which is so very important. But actually, if we focus on the well-being and that big investment, then we are going to be able to really make a difference around health inequality. So We work with small businesses, but also inclusive growth, but innovation, investing in innovation is going to allow communities to kind of come around.
And for public services to invest in those local businesses, which is community asset building, yeah. I wonder whether we have Munro Stewart with us. Munro Stewart is a GP who put a question in advance. If Munro's there, maybe you'd like to ask it. If not, be rest assured, I'll do it for you.
Hello there.
Hi, go for it, Munro. Will you make it short?
Sure. I was looking to see what benefits we can get by action on climate change that also can reduce inequalities. Equally, what action on inequalities can improve the climate situation? And could these also reduce demand on our health services?
Thank you so much. I don't know about you, but I'd love to hear what Professor Sir Michael Marmot has to say about that.
We did a report last year on sustainable health equity, and there was a negative and a positive approach to it. The negative approach is if you take action on climate change and don't have equity at the heart of what you're doing, you could make health equity worse. You could make health inequalities larger. So, for example, a green tax. A green tax is, economists love taxes. A green tax, perfectly good way to deal with climate change. It's regressive. It's regressive. So wouldn't it be a good idea to tax people's home heating now? It would be dreadful. It would be dreadful. So if you say we're going to tax home heating because green taxes are good for climate change, you drive people into absolute poverty. So one has to take health equity into account. Otherwise, your climate change strategies may make health inequalities worse. But going the other way, what we showed is, I mean, take an obvious one, transport. Sustainable transport, walking and cycling, is good for health and good for the planet and good for equity. So you can achieve net zero with policies that are good for health equity, but you've got to take equity into account when you're designing it. So there's no trade-off here. There's a community of interest, and that's why my 8th recommendation was putting the sustainability climate crisis agenda together with a health equity agenda.
Thank you so much. Munro Stewart, you wanted to come back in again. Hello?
Hi, no, that's fine, thank you.
Go for it. No, you're right, you don't want to come back in. Sorry, you had your hand up, never mind. Thank you very much. There's a question come in from Vasily Kolovu saying the speakers have talked about streamlining and centralization of efforts to reduce inequalities. I wonder if that would be contradictory to giving power back to the population in question. I'm going to come to Katie on that. Sir Michael Marmot in his 2020 report, the way that I read it, and I'll check with Sir Michael whether I read it right, is, you know, for real centralized government direction on this, serious focus, getting rid of silos across government departments, considering health inequalities across all the briefs. Is that contradictory to a decentralization that is about local community ownership, and perhaps addressing this democratic deficit that has been identified?
I think from my perspective, this is so interesting, and it's down to the relationships between central government, between local government, between the communities they serve. And I think that, it's, just making that statement, I can't stop there. It's important that we actually focus on what those relationships are now and what they need to be in the future as part of a reform. I completely agree there has to be vision and investment from central government, but then there has to be a localisation of the implementation in an empowering way at a local level, in a way that is different in different areas based on what those needs are. So it's a bit messy, and quite often governments don't like messy responses, But actually, if there's a good enough vision and a fair enough investment, then the local solutions, if they're owned by local people, will start to work. And I've seen that happening in community asset transfer, big, over 60 asset transfers in East Ayrshire now, people running things for themselves, but us working alongside them, saving money so that we're actually able to invest in other places, but communities doing a better job. So it's what you talked about earlier, Penny, it's a trust relationship that needs to grow and build between each of the different levels of government, but also across, because it's not just silos in national government, there's terrible silos in public service and even across other sectors. So that, to me, we need to focus on collaborative leadership so that we're all at the table together, but it doesn't matter whether we're from central government, a community leader, or someone from local government, we're collaborating for change.
Thank you. Carol Tannehill, we see this discussion, the kind of potential conflict here, there's probably a better word for it, around the National Care Service, and there's a lot of discussion about government direction versus local control. Carol, do you think there's a conflict there, or do you agree with Katie that it can be done with building relationship?
I completely agree with Katie. So I think there is a tension, and there's undoubtedly a need for trust to be built. But I don't think these things are in conflict with each other. But I do think we need clarity about what are the responsibilities of national government. And there are some things that only national government can do. And in addressing health inequalities, they need to do those things. And then there's the issue of what is the wider framework or agreement or whatever term we use that enables this cross-sectoral work and the very local community involvement. And at the moment that all feels a little bit muddled. And I think the National Care Service, we're learning a lot, aren't we, for how that's going. So, we need to be absolutely upfront and recognise that there are tensions here, but I don't think at all they're insurmountable. But people need to be clear what is asked of them and what their part of the picture is in terms of addressing this implementation gap.
Yeah, thank you very much. We could talk about each of these questions, could be a webinar on their own. But here's a comment from an anonymous attendee that I'd like to bring us to as we're approaching the end of this discussion. The wealth gap needs to be addressed. That's what making us different from Finland, says this person. This is further exacerbating health inequalities and reduction in life expectancy. We have the data and research, boots on the ground doing the work, we need permanent work from the permanent funding from the top to make it sustainable. But Michael Marmot, is it all about money ultimately?
Well, let me say two things. One about the wealth gap. Somewhat over the top, I published a report in The Lancet, and I said that on the 9th of March 2020, neoliberalism hit the buffers. And what I was quoting Adam Tooze, economic historian, and what I meant by that, or what he meant by that, was the model that we can leave everything to the market and get government out the way was contradicted dramatically by the huge investment of government, the intervention of government to save the stock market, to save the bond market. The rich countries issued $18 trillion of new debt in 2020 alone, half of which was bought up by the central banks. This is huge intervention. Regrettably, they did nothing about inequality. But there is now a widespread recognition. There are strong vested interests that don't want to do anything about the wealth gap. But there's a widespread recognition that this is hugely damaging, and that the model of leaving everything to the market and letting the wealth gap increase is wrong. It's contradicted by the evidence, doesn't work.
So we've got to close that gap.
So we do have to close that gap. And it's vital. It's not just money, though. If it were only money, then I would have only had one recommendation, and I now have 8
Yeah.
The others are crucial. Money is important, is vital. But when, I'm so interested in what Katie's been saying. When I go to, as I mentioned earlier, we're working with local government all around England and now in Wales. And when I go to talk to people in local government, I expect them to be hanging their heads in despond, wringing their hands, saying it's all hopeless. The settlement from central government has been so appalling. There's nothing we can do. But they're not doing that. Quite the opposite. They're saying okay, this is the hand with which we've been dealt, but there's a great deal we can do despite that. And we're going to do the best we can. So, and it's not just money, it's all these other domains that I talked about.
Thank you so much. We're running out of time fast. Katie Kelly, closing comments here.
Yeah, I'm really delighted with what I've heard. It's absolutely not about money. And I think actually, as I said earlier before, I think investment of money in a stilted way or in a way that flips and flops, exacerbates inequalities. This is about people owning things together, people having power to make change over their own lives and to do things, and things that maybe don't fit tidily into the agendas of public service.
Thank you. Carol Tannehill, post-pandemic, long after austerity, we're in a cost of living crisis like we potentially have never seen before. Do you share that optimism that despite that, we can do something here?
Well, I disagree that it's not about money. I think it's not just about money, but I think money is absolutely at the heart of this, and poverty is absolutely the heart of action on addressing health inequalities. Am I optimistic? Well, I mean, yes, I'm always reasonably optimistic, but there's no doubt this is really, really challenging time. The pandemic has exacerbated existing inequalities. There was a major crisis before the pandemic, and we have tried before to address health inequalities, and they have continued to grow.
Okay.
So we have a big mountain to climb here.
Thank you very much. Chris Cregan, I'm going to come to you for the final comment here, because, what happens with this piece of work next?
Thanks, Penny. So fantastic to hear all the contributions and the questions. It's been hard to keep track of them all coming in. Look, you've heard from Anna and David today. Work is well underway across the strands of work that David talked about earlier. We're still at the relatively early stages, and that's why it's really good to be having this level of engagement today, because I think it's food for thought for us as an advisory group. We're meeting again at the beginning of June, and there's a lot for us to think about here. I think we do understand that what's going to be really important through the course of the review will be to engage with other work, other activity, other opinion and perspective. At the top, if you like, that's definitely going to include a parallel inquiry, which is going on at the Scottish Parliament through the Scottish Parliament's Health Committee in relation to health inequalities. We're already engaging with them. But I can see a huge appetite here to connect with, to engage with us at all levels across sectors. And I think, we need to think about that. Look, in terms of where we're headed, our current thinking is we're not, I talked about 191 policy recommendations, Scottish Government earlier on. We're not here all about detailed policy recommendations. We will be about proposals for action. But I think, given what I've heard about what we have, and I'm a kind of glass half empty optimist in all of this, one of the challenges we have here is about creating a really clear, really coherent narrative, which is informed by evidence and engagement, which can shape future policy direction. And it has to be long-term. We're talking about that retrospective lens, that, as David said, we haven't had the opportunity to do that comprehensive work back to the start of the Parliament. But as Richard Mead said, I think in a question around how does this get sustained, we have to think about long-term change. So, of course, action is urgent. Inequalities urgently need to be addressed. But if we're going to close the implementation gap, we're going to have to think in terms of our change model on what can we do foundationally to contribute to long-term generational change.
Thank you so much. Well, speaking very personally, I am very heartened by what I've heard. I'm reassured that this piece of work is different and is going to bring something fresh to the conversation. I very much look forward to hearing what happens next. To remind you, the recording goes up within 24 hours. There's a link in the chat to receive review updates. I'd like to say thank you so much to a brilliant panel, questioners, and everyone taking part. Bye-bye and good luck.